whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Leaders in Healthcare. I'm Dr. Jordan Vollrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about all things healthcare. Join us as we speak to innovators, industry leaders, and the people working to drive the healthcare system forward. Today we're talking to Dr. Rashaad Bhyat. He's the Senior Clinical Leader at the Center for Clinical Innovation in Digital Health at the Connected Care team at Canada Health Infoway. Now, if you've never heard of Infoway, they're a federally funded, not-for-profit organization. And just recently, congratulations, he was actually awarded the 2024 Clinical Innovator of the Year from Digital Health Canada. Dr. Bhyat, thank you so much for chatting today. I really appreciate it and excited to have you on.
Oh, thank you so much, Jordan. It's please call me Rashaad, and it's lovely to be here, and I really appreciate the opportunity to join you on this podcast.
So why don't we start a little bit with your background? You have a very fascinating story. You started out clinically, your training is in family medicine and more healthcare, but you've made the shift over to administration and digital health. How did that actually occur?
So it's sort of a long and circuitous path. I'll put it this way. I've always, probably like you, I was always interested in technology from a very early age. Dabbled in computer programming, dabbled in, putting computers together when I was a kid, all those kinds of things. And so this continued on into medical school and residency. And again, dabbled in some IT related projects over the years through that sort of academic arc. And in residency, I did my residency over at Memorial University in Newfoundland, which is a pioneering organization in telehealth, by the way, just putting in a plug for Memorial. But, did a project there relating to what was called e-health at the time and digital health. And, was always looking for ways to kind of keep that interest going as I, began my practice in primary care and family medicine, leaving residency, and did a bit of blogging, and that was in the early days of blogs years ago. But anyway, it ended up being me seeing an opportunity coming up at Infoway a good number of years ago, and I sort of stayed with them in a part-time capacity, providing expertise on everything from EMRs to EHRs to clinical information systems to virtual care, AI, everything in between since then. And a lot of what I've done over the years, I think, for your listeners, there are these days many more formal pathways for young people who are interested in health informatics and clinical informatics. And some of the work that I'm doing is really part of it's through Infoway, part of it is outside of Infoway, but a lot of it is just trying to, see if we can make those the instruction of digital health and informatics and newer emerging technologies like AI, if we can see all of those actually being integrated into medical education at both the undergraduate and postgraduate medical education levels over time, so that people have a more visible formal pathway. Canada's a little bit behind other countries, I would say, in terms of having those established educational pathways to be a clinical informatics expert or a health informatics expert. Whereas I think in some other parts of the world, some parts of Western Europe, south of the border in the States, it's a little more formalized. And I think we are heading in that direction slowly. But yeah, it's been an interesting path. It's taken some twists and turns, which have always add a little spice to the day, right?
No, 100%. I think you're hitting the nail on the head too. The education side of things is definitely starting to catch up now. Like I remember the digital stethoscopes had sort of just been the new kids on the block. And, there was a few preceptors who'd give you a little slap on the wrist back if you showed up your clinical rotation with one of those. That was seen as cheating. And so they were like a little bit more old school that way. And we see similar kind of things with the technology, across the board, whether it's the computer systems, the hardware. Canada, like you mentioned, is due for a bit of a makeover, a bit of a refresh technically?
Yeah, and I mean, again, not to, there has been lots of progress, I think, over the past 15 years, and a lot of it for physicians, in particular, just to use that example, has come not necessarily directly through medical school or residency training, although there is, as you alluded to, that is changing, which is great, through organizations like the Royal College of Physicians and Surgeons of Canada and their CanMeds process. There's some work happening there. The Medical Council of Canada has done a bit of work there. There was some work done with the Association of Faculties of Medicine of Canada, AFMC, a few years back. So all of these little pieces, and the medical schools themselves have been individually working on innovations in this area. So again, I see it as a glass half full type of scenario in the medical education domain relating to digital health and informatics. But again, it's a journey.
And so, where does that leave us, in terms of Canada's digital health landscape? I love that you've started out sort of tinkering with computers, that personal love for just technology and fascination there. Just side note, I actually just finished building a PC like a couple days ago. I spent part of my lunchtime benching, stress testing, and adjusting the fan curves for my CPU. And so I find myself definitely in a similar state of mind here. But yeah, how did you wind up combining that love of technology now with your healthcare background and training in medicine to then start seeing things when it comes to the digital health landscape across our system in general? What sort of trends do you want to see taking place?
Yeah, it's a great question. I've been really fortunate, again, working with InfoWay because it has a pan-Canadian lens on things digital health related. Through its mandate, I've had a chance to, meet with doctors and nurses and pharmacists who are interested in the space over the years in many provinces and territories, and to see what's been happening. Obviously, my home base is Toronto. I practice in Brampton, Ontario, and my home province is Ontario. But I've been able to see sort of what's happening in parallel, and Canada, as you know, based on our unique structure for healthcare, we essentially have almost 13 individual healthcare systems. However, organizations like InfoWay have played, and our sister organizations, similarly CHI and others, pan-Canadian healthcare organizations, working with partners, we've really tried to help coordinate some of the efforts. So you have seen some digital transformation occurring in each of the provinces and territories. A lot of digital transformation has occurred over the past 15 years. Not everyone is moving at exactly the same pace, but everyone has moved forward like an incredible amount. So again, maybe I'll paint the picture by going back a tiny bit. If you look back to say 2007, which predates my time in the space, but we have some numbers going back that way. The adoption of electronic medical records in the community, so in community-based family practices, was probably around a quarter ish, 24-25% ish. But if you look at some data that we have from the Commonwealth Fund study of 2022, not that long ago, we've crested 93% of family physicians or primary care physicians using EMRs. So we actually, through joint efforts of pan-Canadian organizations like InfoWay plus provincial and territorial partners putting in skin in the game, and of course the efforts, the blood, sweat, and tears of physicians, nurses, pharmacists, but in community-based EMRs, it's been physicians and their medical office assistants and staff who've gone through that tough adoption process, but have really moved the needle in terms of adoption of EMRs, but also using EMRs, electronic medical records, in a more advanced way, the optimization piece. So not just using them as digital filing cabinets, but using them for quality improvement, for data analytics, for eventually adding on pieces like patient-facing tools and virtual care modalities. Now, all of this, I would say, with a caveat that it's highly unevenly distributed across the country. And so that's why that digital transformation is not complete. It's an ongoing process, and just to add a bit more, in the middle of all of that, I shouldn't say in the middle, recently, as you well know, we experienced a global pandemic. It caused pain and suffering for Canadians and people all around the world, but also caused like extreme stress and duress for healthcare providers. So, you know, physicians, patients, healthcare providers, we saw the immediate advantage during the pandemic of being able to use digital tools to provide care remotely, including e-prescribing tools like PrescribeIT. Virtual care tools became normalized. Unfortunately, the stickiness of that adoption has not held up entirely exiting the pandemic for lots of different reasons. Um, but maybe I'll just pause there, and I can also tell you about one of the biggest frontiers that we are, trying to, or sorry, one of the biggest challenges and the next frontier of what we're trying to tackle at the moment in digital health transformation.
Absolutely. I mean, what is the next big thing? The EHR, EMR adoption, that was just the crown jewel of the 2000s and 2010s, still very unevenly distributed, as you mentioned. I just saw some data recently. I think New Brunswick has about half of their family clinics still operating with paper charts. They haven't quite gotten to that point with the digital adoption yet. And then at the same time, there's a big difference between checking the box of like, yes, we use an electronic medical record versus, we are utilizing these digital tools to their full potential, right? So there's so much complexity in there. And again, it's one of those things you need to, train and practice with, just like you do with your needle driver, your scalpel, or any of these other tools that we commonly use. But I'd love to hear, what is the actual next frontier for digital health here? Where's the system heading?
Absolutely. So many, in answer to that question, some might sort of anticipate that my answer is going to be AI and AI power tools. That's actually not the answer. AI and AI power tools are fascinating. They are a new and emerging technology that has the potential to do lots of really interesting things, if harnessed in the right way. But actually, the answer I'm going to give you, the biggest frontier right now is the lack of connectedness between systems that physicians use and other healthcare providers in primary care and acute care settings. The lack of ability to share information, that interoperability that we speak of in the digital world, that contributes to what stuff that you're hearing about in the news, administrative burden. Physicians again just came out of a pandemic. Healthcare providers, doctors, nurses, others, lots of stress. That stress now, you come back to the sort of post-pandemic world, and that stress is not completely allayed or hasn't gone away, because you're still dealing with tools that are very, very challenging to use to allow you to try and get through your clinical day and provide patient care, spend time with patients. But if you find that you're being hindered by the tools that you're using and the system in which you're operating, that administrative burden is really challenging. It's due to systems that rely still very heavily on fax-based technologies, paper and phone, and just tools that aren't speaking the same language and haven't necessarily been encouraged or incentivized to speak the same language and to share information where it's needed at the right time for appropriate and the best patient care that you can provide. And so, I could get right into very specific examples of this. Jordan, you know these well from your own practice, but doctors across the country every day are spending tons of time trying to chase down information that they need when a patient comes into the office. We're always missing pieces. We haven't received this report from that specialist. We haven't been able to access this hospital bit of data for this reason. And, it's often, a very challenging conversation explaining to the patient, why you don't have all that information. This is despite best efforts of office staff, hospital staff, lots of individuals in the system who are trying their best to keep things moving, but they're dealing with tools that are antiquated and not really optimized to provide optimal patient care, but also safe patient care. And I'll get to that in a second, in the sense that, if you look at the broader landscape of this frontier of tackling connectedness of care or interoperability, there's been some amazing work done by lots of individuals across the country, including, especially in Alberta, the Alberta Virtual Care Coordinating Body, for example. They got together, they were formed during the pandemic, and they've produced a recent report called the Interoperability Saves Lives report, which outlines how a lack of interoperability or connectedness of digital systems can actually harm Canadians. And this work, plus the work of folks like Terry Price and her father in Alberta, building on the story of the very sad story of her brother, Greg Price, all of that work is built towards a recent announcement by the federal government about a week and a half ago of a Connected Care for Canadians bill that is really intended to accelerate interoperability across the country, break down silos of information that prevent information being shared at the right in the right place at the right time for the right people, so that people have that information at their fingertips to be able to provide the most appropriate care for patients, who are, especially those who are the sickest.
What is the story for the Price family for anybody who hasn't heard it?
Yeah, if you I could only say this in broad strokes. You should really visit the website Greg's Wings and learn about the story. There's a whole well-produced video production that the Price family put together that is actually being taught at medical schools in some parts of the country. But it outlines how Greg Price was really encountered a very, very unfortunate, awful situation that compromised his health and eventually his life due to not being able to navigate the system, the healthcare system. He didn't have a primary care provider, if I remember at the time, and was experiencing certain symptoms that led him to various after hours clinics and urgent care centers and emergency rooms. But ultimately, it was a lack of communication of health information that contributed to the really sad outcome that Greg had. And Greg's dad and Greg's sister Terry have really dedicated their lives to trying to fix that since then. Looking at it through a quality improvement lens, looking at it through a patient safety lens, and that advocacy work has really contributed to where we are now, which is really trying to break down fundamentally how laws in Canada treat health data. Right now, at the moment, it's a very custodial model, meaning there's a sort of an incentive for healthcare providers to protect and own, in quotations, patient data, whereas the idea is to move it more towards a patient-centric model, whereby the data is yours and you should be able to access it as a Canadian, as a patient. And other countries around the world are looking at this through a similar lens as well, and taking an interoperability, looking at a focus on advancing interoperability to move that forward as well.
And then, so I guess kind of going back to the focus of interoperability, then, who actually sets the standards for interoperability? The EMR to the hospital system to different provinces. Who actually is steering the ship there for everybody across Canada? Is it different province to province? Is this like a regulated thing that comes from the top down? Is it sort of a free-for-all in that everybody chooses how they want to go about it? Who actually sets the beat for this?
Yeah, so these are great questions, and the answer is complex. And again, I'll go back to the nature of Canada's healthcare system. So in our federal system, healthcare falls under the domain of provinces, and so the provinces and the territories control healthcare essentially with support and assistance and coordination from the federal government. And so if you look at the digital health landscape and how it's evolved, InfoWay, part of the reason we were set up was to help coordinate national standards. And so InfoWay does do that. We are sort of a national pan-Canadian clearinghouse for standards, whether it's being the liaison with HL7 internationally or SNOMED CT as a terminology nationally and internationally. However, provinces and territories and individual healthcare systems over the years have made decisions, to pursue certain paths that they thought were the right decisions at the time. And there's no judgment in this, because at the time there was no and still isn't any legislative authority at a federal level to say, thou shalt follow these specific standards. And so we're starting to see the needle move and change in that direction, towards having a more of a stronger, better coordinated pan-Canadian approach to standards. And we are hearing from provincial and territorial partners and Health Canada, and partners like CIHI and StatsCan, that this makes sense. This is, in 2024, there is a clearer path to which standards to use or which standards to leverage and build upon. That was one of the other challenges over the past 15 to 20 years. There were many standards, some of which have now been outdated and replaced and consolidated. And so I would say that in 2024, it's much easier. I shouldn't say much easier. There's a slightly clearer view to how health data standards could proceed at a national level. And we can take cues from countries who do have the benefit of having a national healthcare system, meaning they have more of an ability to influence what healthcare providers and healthcare digital health vendors do at the national level, versus having provinces and territories work on their own thing with a coordinating type of approach, which is what InfoWay tries to do. We do our best to try to bring people together, and there's a very good example of that that's happening at the moment, and that's around the emerging pan-Canadian patient summary standard, which is aligned to an international standard called the International Patient Summary, IPS. So InfoWay, on the technical side of our organization, has done all the mapping and outlined what the pan-Canadian standard is. So Patient Summary Canada, which maps and aligns directly to Patient Summary, the International Patient Summary. Now, each of the provinces and territories have their own variations on that, but the idea is that InfoWay is really working closely with them to try and align those provincial and territorial standards so that they line up very, very closely with the pan-Canadian standard, so that theoretically in the future there will be more interprovincial and provincial territorial the ability to share a patient summary across borders, because Canadians do move, as we exist in this country. But so there's a lot of interesting work going on that right now, and I think that's a good example of where things could be going. And we are hearing that from not just provinces, territories, and Health Canada and our people at InfoWay and CIHI as well, but also hearing it from vendors that it makes sense to stick to one set of standards. We're actually looking for one set of standards that we can build towards, and we'd like to have tools to be able to build towards those kinds of standards. So I hope that gives you a rough idea. It's the standards, influencing standards and making sure that everyone uses the same standards. It's an extremely complex landscape and situation that has been evolving. But I do think it is heading in the right direction. And again, that legislative announcement, which is an act, it's a bill, not an act yet. But it's a step in the right direction in terms of encouraging provinces and territories and vendors to increase efforts to share data using a pan-Canadian standard.
What does a standard even entail? Like, in my head, I'm kind of picturing like you take a EMR entry and you basically flatten it into like a single column of a spreadsheet with the date at the top, and this belongs to Steve, and that's got the blood pressure, the doctor's notes, the whatever. Like, what are these standards actually defining as to how the computer systems talk to each other back and forth?
Yeah. So, and I'm going to caveat what I'm about to say with, I'm not a standards expert. So there's a whole, expertise and, whole domain of expertise around standards relating to terminology and the transmission and sharing of health data. But essentially you're right. It's basically making sure that data fields that, say, an electronic medical record would use, that a health information system would use, that a provincial electronic health record like Netcare might use, or and when I said health information system back there, I meant the epics of the world, for example. So making sure that the data fields in those different systems follow a similar format and can thus be put into a standardized package to be exported from their system to another system, so that the system at the other end knows exactly how to digest that package and unpack it into the same fields on the other side. So a good example is the patient summary standard. So the delivery, and again, I shouldn't get too far into depth on this just because it's not my area of expertise, but for doctors and nurses, when you say the patient summary standard, when I talk to my peers, or if I'm at a conference, it's very confusing. Like, what do you mean by the patient summary standard? Like, what is that, right? Well, doctors and nurses, we don't call it that. We call it a cumulative patient profile in our electronic medical record, or the patient history. When you're in medical school, you learn how to take a very detailed patient history, and it includes all these fields, like the patient's medical problems, the patient's past surgical history, the patient's medications, the patient's drug allergies. All of those are standardized fields. There are organizations internationally and now nationally, InfoWay, who have mapped out how that should be packaged and how that data should look in a very standardized way, and how it should be communicated between systems. And so that's one type of a standard. Another example is a terminology standard. So something like SNOMED CT. So if you look at in an electronic medical record, when you're entering a diagnosis of diabetes, unfortunately, electronic medical records across the country in primary care in particular are still using very old disease classification standards, primarily because EMRs have a billing function, and the billing systems were using that. So just to come back to diabetes, so many EMRs are still using, if you're entering a billing and or diagnostic code sometimes for diabetes, it's 250, ICD-9, still in Canada in 2024. Now ICD has moved forward, but SNOMED CT is being adopted as a terminology standard across the world, and we could see potentially in the future that there may be a move towards, first of all, not requiring doctors to have to learn all of the standard components. Really, doctors shouldn't have to be data entry clerks and to know all about that necessarily. We should have systems that are smart enough so that when a doctor enters diabetes into their patient medical history, in their cumulative patient profile, in the back end of the system, it's automatically translated or mapped into whatever the billing system for the province is using, number one, a terminology standard, number two, and into the patient summary standard, number three. So all of that stuff should theoretically happen behind the scenes. And, those are the kinds of things that doctors don't really want to do. We don't want to be data entry clerks. And there's a lot of discussion, particularly relating to the administrative burden in primary care and in medicine in general, relating to that links back to digital technologies to make it easier for doctors and other healthcare providers to do the right thing when they're functioning, working within their clinical information system, whatever that might be.
And so what does InfoWay see as the path forward on this? Like, I imagine there's a ton of legacy software and these just old systems across all of the provinces. How do you actually move things forward and create that interoperability, knowing that, these provinces, the billing systems, all these different legacy systems are in no hurry to change. Like, we've had the same backbone for our billing system here in Alberta for like close to half a century, I think. Like, how do you contest with that?
Yeah, so we could spend an entire podcast or two. We could have a series of podcasts to answer that question. I'm going to try and summarize it using a couple of concrete examples. So first, it's not impossible. it's not impossible to move forward on interoperability. I'll use a tangible example. PrescribeIT, or Canada's Pan-Canadian National Electronic Prescribing System service, is a very good example of interoperability in action. So it does use a FHIR-based standard underpinning that transmission of the prescription message, and that standard essentially is a pan-Canadian standard. There's a couple of minor variations, but essentially it's a pan-Canadian standard. So that has been a real success story over the past 7 years. And the other aspect of that success story is not just establishing a pan-Canadian standard for electronic prescribing, which is important. It's not just that there's a standard for the message transmission. There's also a drug database standard that was created to coincide with electronic prescribing. But the additional success was getting vendors on both sides, meaning when I say both sides, I mean on the pharmacy software management software system side, and on the electronic medical record side, getting vendors on both sides to say, okay, we're gonna use this one standard that you guys are proposing, and we will integrate it into our software. Now that was a challenging journey. It came with lots of discussion, lots of negotiation and lots of work, but it's managed to get most EMR vendors across the country on board, the vast majority of pharmacy management software systems and pharmacies on board as well. So that's a very tangible example. But back to your question, how do you move this? How do you chip away at this massive problem? Well, Infoway started with partners, Health Canada, CIHI, StatsCan, a pan-Canadian interoperability roadmap. And that roadmap is something that other countries have used successfully around the world, some of our peer nations. I would say countries like New Zealand, Australia, the United Kingdom, other countries in Western and Northern Europe have used similar approaches. You have a roadmap and you have goals, and you start to work towards small goals and encourage partners, including the private sector and the public sector, to come together around the idea that for the public good, it makes sense not to be all speaking different languages. There's no point in having a VHS Betamax war that predates even my time, but that's an old example. There's more modern examples now. Your iPhone versus Android phone. There's still standards that connect those together, but anyway, those are other examples. But there are 4 pillars in this pan-Canadian interoperability roadmap, and they're focusing on different aspects of interoperability, improving data portability using a standardized data set that CIHI is working on and Infoway is supporting, establishing pan-Canadian standards for e-consult and e-referral, so that as those services develop and move forward, they are using one language, so to speak, or one specification, ideally, and also providing Canadians with more access to their own health records. And keep your eye on that space, because that's a very powerful part of interoperability, giving patients good, solid access and reliable access to their information. And we will be seeing some of that happening quite soon in a couple of different provinces. So keep your eye on that space. And some of that is tied into the patient summary work that I mentioned. So I hope that sort of answers the question. It's a huge problem to tackle, but if you have a coalition of the willing, and you have people, you have a vision wrapped around a roadmap that gives you sort of technical milestones that you want to hit, you can achieve interoperability. And there are countries that are, again, working, moving forward in that space. I think Canada, however, is not alone. We are not the only ones who are having trouble tackling connectedness of care in the digital health or healthcare space. It's a problem that is happening all around the world. And interestingly, we look to other countries for some advice on some aspects of interoperability, and vice versa. Some countries are looking at what Canada is doing and seeing how it evolves here based on our unique circumstances.
How do you even get started with something as complex as that? Like, what's the incentive for the individual organizations or these different companies to get going? Because I imagine, when it comes to these standards for communication, you're basically building a network, and the incentive for the first person to join the network is roughly zero, right? It's like, well, there's nobody else on there yet. Like, what's the point of going through all these hoops and these headaches and hassles and development time? How do you even get everybody aligned that way?
Again, yeah, super challenging, and it depends which perspective you're coming from, right? And so you could start, for example, with bringing industry together in an industry collaborative. So that some of that work is happening through with Infoway playing a sort of convening and coordinating role. You can again uh, establish milestones. So the ONC in the United States is an example of an organization that has set out milestones around how certain aspects of interoperability should move forward. So, for example, a pan Canadian, using the example of ONC, it'd be an American, Pan American. Is that a word? Yeah, Pan American data set that would be standardized and that vendors would be encouraged to work towards. In Canada, we're trying to do something similar by building on work that has been done around primary care data sets and trying to formalize that and say to vendors and the public sector as well, let's all agree that these data points are the ones that we'd like to share between systems. And we know you may not be there yet, but in your next iteration, how feasible is it for you to move this far forward? So, and this is me, just saying, take a step in that direction. And I think that's where the conversation starts. And then interestingly, it does snowball in the sense that many people are, I think, and again, I'm not working in the developer or the vendor space, but I think when you speak to developers and vendors who are building products, they actually like to have some guidance, knowing, say, this is the pan Canadian standard that we're all ultimately working towards. If you could keep that in mind as you're doing your quick agile development, whatever, software development process you're using, if you could keep in mind that there are these standards for health data in particular, and use that as goalposts and milestones, a lot of people are happy to say, okay, yeah, we can, that shouldn't be, maybe that isn't a heavy lift, and knowing that that's there and knowing that these specifications are here in language that I can understand, maybe our team can actually use that. So I think that the conversations start small, but then you start to get a group of the willing through working groups, which are happening organically and are happening in a coordinated way as well through Infoway's convening function. You can get the ball rolling in the right direction.
And how's things going in this pursuit for PrescribeIT? Anybody who hasn't heard of this yet, it's a communication, I guess a standard, but it's also a software interface that goes within your EMR, connecting the pharmacists to the physicians to make digital prescribing quick and easy back and forth, right? Especially pertinent for triplicates, opiate prescriptions, medications that could be divertible or abusable. Just having a direct link from the pharmacy to the prescriber without having to have the intermediate of fax machine, which could be breached, a piece of paper which could be duplicated, edited, modified. How's things actually going on this front?
Yeah, so I'm glad you asked. I mean, it's going really well. As I said earlier, PrescribeIT is a really good example of interoperability in action in a very functional way. Like, when Infoway and partners were looking at the Canadian landscape years ago, this is going back to 2016, 2017, Canada was quite far behind other developed peer nations in terms of having the ability to prescribe electronically. So we're and still are heavily dependent on. At the time, it was handwritten prescriptions. Then it transitioned to EMR generated printed prescriptions. As time went on, and through the pandemic, there was a move towards more fax based fax transmitted prescriptions or electronic fax transmitted prescriptions. So it's a very strange environment, hybrid environment that physicians, nurse practitioners, office staff, pharmacists are all operating in. It's heavily reliant still on faxed or printed prescriptions. So the idea was, this is crazy. We should have an ability to transmit prescriptions electronically from one point of care to another. So from an electronic medical record to a pharmacy software system, in a standardized way, using a standardized language. And so that was sort of the fundamental idea behind PrescribeIT. Can we make that more efficient, make it safer, reduce the risks of prescribing controlled substances? For example, diverted prescriptions that have been forged, so a lot of fraud related to prescriptions. Also, enhancing communication around prescriptions. PrescribeIT actually integrates a two-way secure messaging system, which is starting to gain momentum. And years ago, I thought that would be the killer application component of PrescribeIT. The ability to send a quick message back and forth between the pharmacy and the physician's office to clarify small things. So that you wouldn't have to spend a day or two playing fax and phone tag with multiple office administrators, fax machines, and then encountering fax failures and all that kind of stuff, or lost messages, or full voicemail inboxes, all of that kind of stuff that seems really outdated in 2024. So it's a real attempt to modernize how we prescribe and then dispense medication. So to answer your question, how's it going? Well, PrescribeIT has come a long way. It's as I was saying earlier, it has really crested a major hill in the sense that a tipping point has been passed. Most of the EMR vendors in primary care are either conformed or in the process of conforming to PrescribeIT. So you've got lots of EMR vendors now who are engaged. You've also got lots of pharmacy software systems, the technology on the pharmacy side, conforming or conformed, meaning that they have integrated the PrescribeIT transmission architecture into their software. So that watershed moment, I think, took place probably in the past year to two. We're also seeing new provinces and territories coming on board. So, there should be a pretty big announcement coming soon. I don't think I'm officially allowed to disclose it, but keep your eye on that space in terms of a major provincial announcement. It just, when you think about it, you step back and you say, if I was talking to a young graduate coming out of a family medicine residency or a medical student, and I said, hey, we're doing electronic prescribing in Canada, they would probably look at you or look at me as if I had two or three heads. Like, weren't we doing that 10 years ago? Like, what's going on? Why are we doing it now? Like, haven't we done that already? Aren't we already doing that? Is sort of, those are the questions that come to mind. It's baffling, right?
It
like
is.
In every aspect of your life, whether you're dealing with your bank or, setting up travel or whatever it is, you're sort of leveraging electronic tools or digital tools to help you do that, to do it more efficiently, to do it in a way that's safe and secure. Why aren't we doing that with electronic prescribing? So we are trying to do that. And again, there's a huge amount of momentum that has been built. We're in the millions of prescriptions that have been transmitted. I think that momentum is heading in the right direction.
Why has this taken so long? I mean, this is just one of those, such a obvious thing, having a direct one-to-one link from prescriber to the dispenser and the follow-up, knowing whether it got there or not. Why has this been so slow to actually come to fruition?
It's very challenging to understand why, and it's a complex answer to a complex situation. And I bring it back to the complexity of Canada and healthcare in Canada. Again, coming back to our federated system and the fact that we are essentially operating as 13 healthcare systems that are coordinated at the federal level. But electronic prescribing didn't have a mandate. It didn't have a stick that said, to vendors, to providers, that this must be adopted using these standards in this amount of time. Some countries have taken a carrot and stick approach, depending on the country, and that has helped and worked in some regions. So carrot and stick means, on the one hand, you provide incentives and support for the people who are doing the hard work of, adopting a new technology or implementing a new technology. That's not easy, right? Change is hard. And so if you need supports and incentives to help people along that journey. So if you have that, plus you have a little bit of a stick approach, which may say, within this time frame, really, we need provinces and territories, we need you to move towards this goal of having everyone prescribing in this manner because it is safer. That also helps. However, there are lots of challenges in terms of looking at how prescriptions work and how the prescribing and dispensing processes work from a regulatory perspective, not just in one profession, but in two professions. So you have two regulatory types of bodies that you have to talk to and work with, in addition to implementers and users of the technology, the clinicians, so pharmacists and physicians who would actually be using the software, to the vendors who are actually building it, right? And to jurisdictions who are trying to figure out policy. And the challenge is that a lot of this is uncharted territory. So, you're looking for evidence internationally and outside of Canada because, relating to the efficacy and the utility of electronic prescribing. And even doing that was not easy at the beginning because there weren't lots of people doing that and doing those kinds of studies. So we had to do some of our own. So there are all sorts of aspects to the complexity of how moving electronic prescribing forward in Canada has been maybe a longer than expected journey. But I would say it's been a positive story in the sense that it has really moved in the right direction, even if it has taken a little bit longer. And I think it also gives policymakers pause, to observe this as a use case and to say, okay, maybe this took longer than we expected. Is it possible that we could come up with an approach that would, in a safe, secure way, using certain guardrails, move efforts like this forward at a slightly faster pace, right? And again, coming back to electronic prescribing, there's a very strong patient safety argument to be made for use of electronic prescribing. Similarly, that same argument could be made for general interoperability of health data, making the argument that the lives of Canadians, the safety of Canadians, and the optimal health of Canadians is really dependent on us not losing momentum on the interoperability journey.
I mean, it's just such an obvious thing. Like, I'm incredibly grateful and excited to see that there's like something actually now finally addressing this problem. It blows my mind of like, what is so magical about the fax machine? And like, it's not that everybody's married to that. It's just that it's very difficult systemically to launch something better. Like growing up in the early 2000s, my mom had a fax machine, and like that, it was still an antiquated piece of technology at that point. I think she was like the only person I knew that had a fax machine, but she would regularly get, intercepted faxes coming from medical clinics all over the place. Her phone number must have been like one digit off from a pharmacy nearby, and there was just constantly patient information showing up, and like sometimes it'd just be a whole blast of a chart, and she'd get all pissed off that her fax paper was getting used up. I think there was a few times she'd like try and call up whatever clinic or pharmacy it was and get them to pay for her fax paper refills. But like the fax is like far from a bulletproof system. It's just somehow become this backbone of our healthcare system.
Yeah, I mean, amazing points there, Jordan. Like the challenge, the persistence of the fax is kind of mind-boggling to many, and unfortunately, that example you gave of your mom is happening every day. Like that scenario actually happened at our clinic group not that long ago, And sometimes again, it's that just that one digit error that may have been made in entering a fax number somewhere, even in an electronic medical record, because you're still relying on humans to help with some aspects of entering data, and mistakes can be made, and thus faxes can very frequently end up in the wrong direction or end up nowhere. Head into the fax Bermuda Triangle, right? And again, it's patient care that is sacrificed, and that's why a few years ago, there was a mantra that was taken up sort of subtly and quietly in different parts of the world, and that was axe the fax. Can we move? I think it began in the United Kingdom, and sort of expanded elsewhere outside of the United Kingdom, including Canada, to see if we can advance beyond that technology. But the challenge with the persistence of fax is that technologies will persist if there is not a better alternative that is presented to those using the technology. And unfortunately, until now, the status quo has been, in many ways easier, more reliable, and just accessible, I would say. And so I think we will see that as better technologies become easier to use and more intuitive to use, we will see the fax slowly being displaced. And a good example is electronic referral. So as electronic referral as a concept advances across Canada, and again, hopefully eventually moving towards a pan-Canadian specification, you would see that in 5 years' time, young family doctors looking back at how we do referrals right now might say, "What do you mean you used to use fax for referrals?" No, it's just it's all electronic through my system. Now, some doctors already think they're doing that, but what's happening is it's actually electronic fax, so it's still fax, and it still has all the fax-related issues. But true electronic referral is going to displace fax and electronic fax at some point. There will be a tipping point, and that tipping point will come once the electronic referral tools are fully integrated in electronic medical record systems and are really easy and slick and intuitive to use. And there you have a critical mass of specialists who are also using electronic referral, whether they're community-based specialists or hospital-based specialists, hospital information systems adopting the services as well. And we're starting to see movement in that direction, but again, unevenly distributed, which is what we talked about before. And it comes back to that old saying by Douglas Copeland, I think it was, that the future is already here. It's just not evenly distributed. That's a big challenge in health information systems.
I like that. That's a good quote. Yeah, that pretty much sums up Canadian healthcare right there. I mean, for anybody who hasn't actually gotten onto PrescribeIT yet, how difficult is it to get this launched within your EMR?
I would say that it depends on the province and territory that you're in and which electronic medical record vendor you happen to be using. So what I would do if you're interested, the process for onboarding has become much more streamlined over the past few years. So the first thing to do would be to visit the InfoWay and or PrescribeIT site. Go directly to the prescribeit.ca. It's probably the easiest way, and there's a form you can where you can indicate interest. You may also want to reach out to your electronic medical record vendor or pharmacy management software system vendor, and see if they are offering it in your region, if it's being turned on, and that could be the starting point for that journey. Many physicians who are using it, I just spoke to a doc recently who is based in Toronto and runs a very large clinic group, and they introduced PrescribeIT as a means of efficiency, business efficiency, but it's worked out well for them. But they see it not just as an efficient tool that reduces back and forth between pharmacies and offices and enhances, optimizes your medical office assistant, their time, but also physician time. But it also has that added benefit of patient safety, security for prescribing controlled substances as well. So I would say, it's a good idea to look into it, to get on board, and at least get into the pipeline, and see. Hopefully that will be available to you in the near future if it's not already available right now.
So I haven't actually clinically used PrescribeIT yet. Yeah, you mentioned, in the pre-session waiting room lobby there, you guys will be coming to the EMR near me ASAP. We're using like a newer, smaller local EMR, and so we're not integrated yet. But in the coming months, does it just interface, the exact same with your prescription writer that you create your drug name, dose, route, and then you click, instead of the fax button, there's going to be a PrescribeIT button. How do you actually use it?
I'm so glad you asked that question, because that's actually been something that, it's hard for people to conceptualize until you actually see a demo. But, imagine if you're a doctor or a nurse practitioner and you're in your prescribing module, it's essentially the same interface. So you bring up the prescription, you're about to press print or electronically fax, which is what we do now. And instead there's a button for electronically sign and send, or e-prescribe, depending on the vendor. They might call it something slightly different, but that's essentially it. It's just a different button, and that sends the electronic message to the other end. And it means that the prescription data, the patient data, is sent in discrete data fields, and it ends up in the pharmacy management software system in discrete data fields, pre-populating those windows at the other side, which reduces transcription errors. So a pharmacist doesn't have to take a fax or an e-fax and manually transcribe it into their system. So there's that. The other thing that's become more efficient that we've actually been working with clinicians directly on, we have a group of clinicians that we have been liaising with and working with over the years to try and improve the service. And one of them is around renewals. So if you get a renewal request coming in from the pharmacy, that process can be clunky if it's fax-based. It can sometimes be clunky if it's paper-based. The idea is to make that process actually easier to do in the electronic prescribing or PrescribeIT world. So that's something that may change in your interface. You may actually see the incoming prescriptions listed on one side and a matching column on the other side, and it allows you to just click to confirm that these are the correct matches, and then you can generate your renewal from there and make a couple of adjustments. So the devil is always in the details, and that's why, coming back to something we had talked about earlier, working on the user experience and the user interface is really important. Infoway has tried, with PrescribeIT, to establish some best advice guides or best practice guides to help vendors, think about how clinicians would want to see certain types of things presented to them. And so work is definitely going on in that space. But answering your question, yeah, it's very it's intended to be very intuitive in terms of how you generate a prescription electronically.
It's really interesting. I hadn't really considered the other end of the fax machine where there's like the room for transcription errors. I didn't even realize that they had to like transcribe it manually into the computer. Somebody taught me many years ago, when you're sending off a 3-month refill for a patient, put it as 100 instead of 90, because then your friendly neighborhood pharmacist doesn't have to sit there counting the beans out. They can just open the fresh bottle that usually comes in 100. That's the standard. And so this seems like another great way to have your local neighborhood pharmacist like you as the prescriber, sending them forms of 100 and then using the e-prescribeIT tool as well.
Yeah, I mean, there's all sorts of, interesting things that can happen with, and things that we probably haven't predicted might happen in terms of communication relating to the prescribing and dispensing, the whole medication management process. When you sort of start to make some of the processes less cumbersome, and then you add a communication tool on top of it, you're actually encouraging better communication around patient care. So within a patient circle of care, a patient would want to know that their pharmacist and their doctor are able to sort of, connect back and forth in a relatively pain-free manner, which is often not the case at the moment, and to communicate in a modern manner. So, those tips that you just mentioned, like that one around 100 versus 90. I mean, that's something that could be shared maybe, with better communication. The other interesting thing is, we heard this interesting scenario for post-operative patients. There were a few surgeons I remember talking to who said, and I mentioned this because PrescribeIT has moved into the acute care setting. So we are integrating with some hospital information systems now in sort of pilot projects. But coming back to post-operative patients, often there's a need to prescribe pain management or pain control medications. Sometimes those are controlled substances, and I've heard from some surgeons that there's a real reluctance to want to provide more tablets, particularly narcotics or opioids, than the patient actually needs. But at the same time, they recognize that sometimes patients are traveling in from great distances, and it's not. They want to also make sure that the patient has enough. And so with a system like PrescribeIT, with the ability to prescribe remotely, you can actually prescribe remotely, but safely and securely, knowing that you can prescribe to that patient's pharmacy that's 100 miles or 300 kilometers from where you are. If that patient has come in from a remote and rural area, if you know that you have that electronic communication and that secure pipeline, you can actually prescribe more conservatively, more in a safer manner, in a secure manner, and have that communication going back and forth with the pharmacy team around, that is better suited to the patient's immediate needs, I think. So there's all sorts of interesting scenarios that come out of this that, again, ultimately benefit patient care.
Super cool. And this is all free for the prescriber, is that correct? It doesn't even cost you anything to get this integrated in your clinic?
That's right. Yeah. And part of that is, of course, Health Canada backstopping, and providing the seed funding for all of this. Eventually, PrescribeIT is intended to be a self-sustaining service.
Is there any reason not to use it? Is there a certain demographic audience or segment of the healthcare world that would actually be disserviced by starting to use PrescribeIT? It seems like another one of those no-brainers here. What am I missing?
I would say that there is not. Like, I would say that PrescribeIT or electronic prescribing broadly as a concept should be part of the 21st century physician's digital toolkit. So, especially if you're a primary care provider, but also if you're in acute care, you should have access to a suite of tools that is, intuitive, straightforward to use, modern, and digital. So you should have access to electronic prescribing and should be able to use that. You should have access to electronic referral, ideally electronic consult. Those two are part of the same continuum in some places, but you should have access to all these tools at your disposal.
Okay. Well, I guess, Dr. Bhyat, being respectful of your time, we might as well wrap it up there. We'll have to have you back on the podcast another day to chat more about interoperability. I'd love to learn more about why I can phone a patient, but I can't text them, why the patient health record cannot transmit through email, yet the rest of the world, corporate secrets, government, top secret classified stuff all lives in the world of email. And yet, as soon as if a patient were to complain, you can now send health information back and forth with your lawyer. Yeah, I would love to dive into all these more, maybe even on the subject of AI as well, since it sounds like that's another big upcoming, forefront of digital health. But thank you again so much for joining us today. I really appreciate it. I learned a ton today just about the interoperability. I love to see the things coming through on the PrescribeIT side of things. Honestly, I can't wait till it integrates with Ava and we can start using it at our clinic there. But otherwise, I don't know if you have any last things to shout out or anything else, please feel free. Otherwise, I will let you enjoy your afternoon here.
No, I just wanted to say a huge thank you to you, Dr. Vollrath, and I really appreciate the opportunity to participate in the podcast, and a great deal of respect for you and your listeners, and good luck with the podcast itself. Thanks again. This has been really fun.